Hello, everyone. Welcome to another webinar from the AMA Steps Forward Innovation Academy. Today, we'll be discussing demystifying digital medicine coding. Over the next 45 minutes, we will share how to navigate a few CPT codes for digital medicine with real-world care delivery scenarios and practical tips for supporting your coding process, building off the AMA's recently released Digital Medicine Clinical Scenarios Coding Handbook, which you will see linked in the resources widget on your console. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for any specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. Codes and coding guidance do not constitute clinical advice, address, or dictate payer coverage or reimbursement policy, or substitute for the professional judgment of the practitioner performing a procedure or performing a service, who remains responsible for correct coding.
Thanks so much, Alec. I appreciate it. Hello, everyone. My name is Amanda Azadian. As care delivery continues to evolve outside of the brick and mortar settings, CPT codes are updated to reflect these changes. RPM codes have been around for a while, and so as codes and services will continue to evolve, we are here today to demystify that process. So in this session, you'll learn more about the digital medicine codes available today and how to accurately apply them in practice through real-world care delivery scenarios and discover valuable resources to streamline your coding process. On the webinar with us today is Leslie Prellwitz, Director of CPT Content Management and Development. And we also have Ramkissoon, the Director of Ecosystem Management in the Improving Health Outcomes Department here at the American Medical Association. We'll move to the next slide to discuss briefly our learning objectives. We'll go through these today, learning the proper coding strategies for digital medicine services being provided in a practice and organization. You'll receive education on coding for medical services involving self-measured blood pressure, SMBP, RPM, since folks on the call know what these acronyms are, and other virtual care scenarios. We'll also be able to discuss and answer your questions on coding scenarios and resources among colleagues and organizational practice leadership. To that end, for the next 30 minutes or so, we will begin with a brief introduction to the coding process, discussing the ways of enabling high quality care by demystifying the coding process, and then we'll get into 3 clinical scenarios and then finish with Q&A, as I mentioned. We will be dropping links into the resource area of On24. So as Alec mentioned, there's that little area where you can find those links, including the newly released Digital Medicine Clinical Scenarios Coding Handbook. So in case we don't get to all of your questions today, we will also be able to provide a email proxy box where you can direct specific questions about coding scenarios directly to the team here. All right, so we'll jump into a brief introduction to the coding process. As many of you know, the CPT codes provide a uniform nomenclature for coding medical procedures and services. Medical CPT codes are critical to streamlining reporting and increasing accuracy and efficiency, as well as for the administrative purposes, such as claims processing and developing guidelines for medical care review. People are already probably very familiar with CPT, but perhaps not the structures and the people who are behind the code set. So we wanted to take a brief moment to provide some additional visibility into 2 key groups who are instrumental in that process. One is the CPT editorial panel. It is a group of 21 members appointed by the AMA Board of Trustees. They have the responsibility of creating, revising, and updating codes, descriptions, and applicable guidelines for appropriate CPT coding. The code set is made and maintained for physicians by physicians via a rigorous and transparent process. The panel is supported in their work with input from stakeholders throughout healthcare, including clinicians from specialties across the House of Medicine and other qualified health professionals that utilize CPT codes, payers, laboratories, and device manufacturers in standing work groups. This editorial panel revises the code set on a regular basis. So today we're going to be sharing some specific examples of how it was recently updated to better describe digital health services such as RPM and telehealth. The second piece is that the AMA Specialty Society Relative Value Scale Update Committee, or the RUC, much easier term to say, is a second physician-led group that rigorously reviews new and revised CPT codes and prepares valuations of work efforts and other inputs to provide those services. Those relative values are provided to the Centers for Medicare and Medicaid Services, or CMS, who then use that information when determining payment rates for services for Medicare beneficiaries. CMS then publishes the codes, relative values, and payment policies for government health plans, streamlining reporting and payment for digital medicine services. So if we go to the next slide, we can see how we typically think of CPT maybe out there in the world when we're not deep into the understanding of what CPT can really offer us. Most people think of the common uses for CPT. When they hear this term, they're thinking of it as a medical code set. It does do that. It does provide for claims-based reporting and enables fee-for-service payment. All of these functions are important, but there's more. Next slide shows that CPT also supports value-based care and other alternative payment models, quality metrics, and it contributes to the research to provide the efficiency, the efficacy of certain procedures and interventions. The CPT code set is often described as the language of medicine, and the more than 11,000 CPT codes in use today serve as the standardized terminology for communicating the use of medical, surgical, and diagnostic services across healthcare. So those codes are the foundation of how healthcare procedures are tracked, reimbursed, and then studied for future use. If you have questions about the CPT codes, you can either hold on them so that Leslie and Nar can answer them at the end, or you can drop your questions into the Q&A box as they come up. We'll also, like I said, share an email address that you can address some of those more specific questions to as well. So on the next slide, I just wanted to mention that there has been integration of new models of digitally enabled care, as we've mentioned. There are additional opportunities to address that quadruple aim. For example, when we think about value, it's important to go beyond the dollars and cents and look to the metrics, such as clinician satisfaction, patient experience, clinical outcomes, access to care, and cross-cutting values such as measuring equity. The AMA Return on Health report, which you see here on the screen, provides a detailed look at how we can realize the value of virtual care more holistically. This report and other past work, such as the Future of Health Commercial Payer Coverage for Digital Medicine Codes report, inspired the creation of this new resource that we will be discussing today. We continue to field questions from physicians and practices on how and when to use these codes, and we hear from payers that there is not a lot of use of certain codes such as RPM, so we aim today to advance the use of these codes for proper tracking of services and emphasizing the importance of these codes in continuing to really generate evidence for the impact of digital medicine on an ongoing basis. So now I'm going to turn it over to Nar and Leslie. You can move to the next slide. This is just showcasing this new resource. So if you scan this QR code, I think it will also be in the resources section, but this is here for the recording. Then you can access the Digital Medicine Clinical Scenarios Coding Handbook. Okay, I'm going to pass it over to you, Nar.
Great, thanks, Amanda. And I am sure that this is going to be a resource that's going to be in high demand. So I'm with the Improving Health Outcomes group at the AMA, and our team works to address the burden of chronic disease in this country with a focus on cardiovascular disease prevention. We see so much potential for digitally enabled care to increase access for patients and also accelerate team-based approaches to manage them remotely. But we do recognize that there are a lot of questions around how digital medicine can be implemented in practice. Questions like which patients are right for these types of services, who can provide the services, and which CPT codes should I be using. And that's why we wanted to develop this resource. And I'm very glad that Leslie is here with us to help address some of these coming questions. Leslie, do you want to do a quick introduction before we dive in?
Sure, no problem. Thanks, Nar. And hello, everyone. Great to be with you today. So I'm Leslie Prellwitz. I'm the Director of CPT Content Management and Development here at the AMA. So I am in the group in our CPT area. We are the ones who are responsible for curating all of those 11,000 plus codes and making sure that all the decisions of the editorial panel and all of the societies who support them are accurately reflected in that code set. The other thing that I have responsibility for here with my team, very thankful for, is our education and information services team. So if you ever wonder where all of your CPT questions go to be answered, if they come through that mailbox, they're probably coming to my team. And it's been great to see all of the examples that have come through already. We've gotten some pre-questions, certainly a lot of interest out there. And I think that the guidance that's been prepared for you. We're going to go through a few scenarios here. The guidance with the QR code that you saw on the previous slide, that actually contains about 15 different scenarios. We certainly won't have time to go through all of them today, but we chose 3 as sort of a highlight to give you a sense of how the codes work. I would definitely recommend, in addition to what you see today, make sure you take a look at the handbook as well as additional CPT coding resources. As we know, sometimes the devil is in the details, and you want to make sure that you got all those guidelines just right. So with that, I'll hand it back over to Nar, and let's go into our first scenario.
Great. So again, we'll cover 3 specific scenarios. First, we'll start with virtual visits, then remote physiological monitoring, or RPM, and then self-measured blood pressure, or SMBP. Again, as we talk through these, you'll see that they kind of go from fairly broad to more specific. And before we get to the scenarios, I'll just quickly describe each of these to set us up for actually the coding guidance. So next slide. Okay, so virtual visits are basically any telemedicine visit with patient communication that's happening via audio or video, where digital technologies can be used to facilitate the visit. So you can think of it as clinical care that's delivered over a phone call, video call, or through an app or other digital solution. I just wanted to note that 87% of physicians use some sort of telemedicine in 2021, and that's remained consistent. There also seems to be interest from those who are in value-based care arrangements. And I think that just really highlights the potential operational benefits of these virtual visits, while offering more convenience and engagement for the patient, which again makes sense because there's a wide array of clinical conditions that can be managed virtually, like chronic diseases, mental health, and less severe acute illnesses. Next slide. And there are also several conditions that can be monitored remotely using RPM solutions that are able to capture patient vitals, other health data, and transmit them back to the care team. And really, an entire industry has sprouted up with many vendors out there offering connected devices that sync up with apps or data platforms. Now, with RPM, patients get to use one or more devices like a blood pressure device, glucometer, scale, pulse oximeter, all from the comfort of their own home. And the care team is seamlessly receiving data that they can then act on. Now, RPM can be used to monitor patients that are discharged after a hospital stay to prevent readmissions. But really, the big opportunity is to better manage the chronic conditions that account for the vast majority of healthcare spend today. Now, RPM can get those patient insights to the care team in between those office visits. And we see that health systems are investing in the infrastructure. Physicians are enrolling patients with chronic conditions in these programs. And what we're actually seeing is that hypertension is the top use case for RPM based on Medicare claims data. So RPM definitely has a lot of promise. It may still not be available or appropriate for every patient. So we did want to highlight another option for patients specifically with hypertension that could offer a little bit more flexibility. Next slide. And that is self-measured blood pressure. So SMBP allows patients to take their blood pressure readings at home or in a community setting, but it doesn't have to be through a fully automated digital solution, nor does it require using a connected device. So there are so many people with hypertension out there that SMBP can really help meet the needs of practices and patients where RPM may not be feasible. Now, we do recommend the patients follow an established measurement protocol to get their blood pressure readings, at least 12 readings over the course of 3 to 7 days to get that good average. And I do want to point out there are three main components, for SMBP to consider to be most effective. And first is that the patient uses a device that has been validated for clinical accuracy. Now, an easy way to find out which devices are accurate is to check the validated device listing. It's available at validatebp.org. The AMA actually established the validated device listing so that physicians and care teams could trust readings that they receive from these devices for clinical decision making. Now, the second piece is that patients should be trained on how to use the device and educated on proper preparation, technique, how often to collect those readings, and how to relay them back to the care team. And then third, the care team should be providing that ongoing clinical support to help the patient stay engaged, get those readings back as expected, and then make adjustments to the treatment plan. And now we'll go through how each of these various pieces for these scenarios can be captured in the CPT coding. So we'll start with the virtual visits. Next slide, please. Okay, so we're going to focus on the brief audio-only visit scenario here first. I'll go through each of these one by one and then invite Leslie to provide the CPT expertise and guidance for each. So let's start here. For the brief audio visit, an established patient who has not been seen in the past month calls the office after developing a mild rash from an insect bite. The physician is talking to the patient about possible reactions, symptoms to be aware of, and then makes a recommendation that the patient comes in if there are no improvements. And that call lasted 7 minutes. Now, after a few days, the patient rash actually subsides, so they opt not to come in to the office for further evaluation. So Leslie, what do you think is the appropriate way to code for this type of service?
Sure. For this service, we'd probably use one of our newest codes in telemedicine, and that's the Brief Communication Technology Service. And on the next slide, we can go into the details of that. So the CPT code is 98016, and your description is here. So it's designed to be a brief communication technology-based service, just a virtual check-in by a physician or other QHP who can report evaluation and management services. This is in our E&M section of CPT. Key is that it's provided to an established patient, and it's not originating from another evaluation service that's been provided recently, or it's not leading to something within the next 24 hours. Key to this type of service is designed, again, to be brief, 5 to 10 minutes of medical discussion, and not a long meeting, but just a really brief virtual check-in. Now, the point of service, we've noted a point of service for this particular scenario of being a telehealth visit provided in the patient's home. Now, I will caveat this, and you'll see this throughout the guide as well. When we talk about things like place of service codes, many of those are driven by third-party payer rules and guidelines. So CPT does not necessarily define those. And so while we've given some examples here based on the scenario, we always suggest check with your third-party payer to verify the place of service that they will have, particularly with telemedicine codes. A lot is evolving, new rules are being established. And we know that not every payer has the same guidelines. So make sure you check with your payer for your place of service assignment on these codes. A couple of additional items on the next slide with this code to think about. So again, this is a brief synchronous communication technology service. So synchronous, brief, new for 2025. Key item is that it's an established visit, and this is something that the patient initiates. So it's designed to be a patient-initiated service. We've had questions about whether or not the physician's office can actually initiate these brief codes. It's designed to be patient-initiated. It is a time-based code. So it's for a single 5 to 10 minute discussion. It's shorter than other audio-only E&M codes because it's designed to be very quick. Video technology is not required for this particular code. We have some of our newer codes. Some of them are audio-visual. Others are audio-only. This one is audio-only. If in the case it does actually lead to an E&M service on the same day, you have that discussion, someone decides, oh, I think you really need to come in, we need to see you. The time of that check-in may be added to the time of your E&M visit. So if there are two kind of touch points with that patient in a day, those times are generally combined in terms of reporting. So that's the coding for this first scenario. Again, just a brief check-in. I think, Nar, our next scenario is a little more complex, right?
Yes, that's right. Thanks, Leslie. So now we'll get into the remote patient monitoring codes and with the telemedicine scenario here. So in this scenario, a patient is being treated for multiple conditions. They have hypertension, type 2 diabetes, and heart failure. Now, during a routine telemedicine visit, the physician advises the patient to enroll in remote monitoring of their blood pressure, blood glucose, weight, and oxygen saturation. That visit lasted 22 minutes. And 3 days later, the patient comes into the physician's office to receive these devices. So they receive a blood pressure device, weight scale, and pulse oximeter. And they receive also relevant training and education. The devices automatically transmit data to the care team daily. And in that time, the visit lasts about 28 minutes with the patient. And now the patient is expected to use these devices for the next 6 months with regular in-person and telemedicine visits scheduled over that time. So now, Leslie, I'll turn it to you for your guidance.
Okay, well, let's go to the next slide and take a little bit of the look at the guidance for this. So we've got two encounters in this scenario. The first one is the telemedicine video visit, and with CPT, our new code 98004, a synchronous audio visual visit would be the code to use. Now, with these audio visual visits, these telemedicine visits, it's important to note that the physician or QHP still has the option to decide whether or not to report based on medical decision making or total time on the date of the encounter, similar to the other E&M codes. That choice is still there. For this one, 10 minutes need to be met or exceeded, perhaps, but if you were taking a look perhaps on medical decision making, it might come down to something of this nature that's a very straightforward medical decision making scenario. Again, and because this is a video visit, the patient is at home or outside of the office, you have a different point of service code that's different from the second encounter when the patient actually comes into the office to start to pick up the various devices and to get the appropriate training on those. Now with RPM codes, remote physiologic monitoring, important thing to remember is that it's a composite of codes and you use the code based on the component of service that's being given that day. So on the second encounter, there's probably one thing that will be happening, certainly. Patient will come in. You would use code 99453. That's for one of the RPM codes. This is designed for setup and patient education on the use of the equipment. So making sure the patient understands how to transmit various information. Usually this can be provided sometimes by a clinical staff member under physician supervision. No reason a physician or QHP couldn't also perform that service, but there are parameters to allow clinical staff with the appropriate supervision to do that. The second code that you would begin to use, and this would be something that's on a little more timely basis as the patient begins to use the devices and information starts to come back, is that you would use code 99454. Now this is another RPM code. This one is designed for device supply with daily recording or programmed alert transmission. So it covers the provision of the device and to have information start to come back. This is used on a 30-day basis. So if you notice, you would have this code transmitted every 30 days. And certainly for the initial setup and patient education, the patient is coming into the office, so your place of service indicator would indicate the office setup. Now let's go to the next page and we'll talk about a couple of items with some of these codes. So first, key considerations for 98004, telemedicine code. This is synchronous audio visual, so AV codes. The code categories are similar to the office or other outpatient visit setup. So it's very new versus established, various levels of service. The structure is very similar. And again, you still have the option to report based on medical decision making or time based on what's most appropriate for that patient in that encounter. Now, because telemedicine is inherent in these codes, as of the time of this webinar, these codes are not on the appendices in CPT for modifier 95, which would report codes that are eligible for reporting in audio-visual mode, or modifier 93, codes available to be reported in audio-only mode. And the reason for that is that telemedicine is inherent in these codes. It does not require modification in order for telemedicine to occur. They were built that way. Important to note with these, you would not report them with the same day in-person E&M. Again, if you have that scenario, you would usually combine the time and report as one E&M code. Question we often get with audio-visual, somebody asks, well, what if we lose the video? How do we report that? And the goal is that you would report the service that accounted for the majority of the time of the interactive portion with the patient. So certainly you could start out as audio video. If for some reason that stopped 5 minutes in and you had a 30-minute visit and most of it was audio only, you could certainly default and report that with an audio only code, and there are companion codes for that. So I think that's, let's go to the next slide, and we'll talk a little bit about some of the key considerations for RPM codes. This is encounter number 2. So 453 is designed to report the setup and patient education on the use of the devices. Sometimes people say if there's multiple devices, how many times do we get to report this code? From all that we can discern so far, you will report this once per episode of care. So we would employ you when you're doing the initial setup and education, should be once per episode. 99454, again, this is reported once every 30 days, so it's a longer time frame, and the device has daily recording or programmed alert transmission, and that's different from manual recording. This is why this code may be used if you're, say, looking at hypertension and the patient is using a device where it's automatically sending data back. That's different from the SMBP code, which gives you more flexibility in terms of, say the patient does not have an automated device. They're recording it manually to submit. So there's a little bit of flexibility in those codes. Key thing with 99454, and this is part of it, is that you don't want to report that in the same calendar month as the self-monitor blood pressure codes. Usually that means there's an overlap in service, and as with CPT, we know that every minute is only counted once, and there should not be 2 ways to report a service. So it'll either be remote physiologic monitoring if the time of the monitoring, the devices used, and all the other criteria meet the criteria for RPM, you would use it. If it's something that's perhaps a little more manual, or it's not being recorded for this length of time, you might find the SMBP code, if you're monitoring blood pressure, may be more appropriate. Couple things for both codes. When you're using remote physiologic monitoring codes, if there's a device, the device does need to be a medical device as defined by the FDA. The service does need to be ordered by a physician or other qualified healthcare professional, so you do have to have an order. And you would not be reporting these if the monitoring is less than 16 days with the current structure. So I think that's it for this one, Nar. Let's go to number 3.
Great, and a great way teeing up the self-measured blood pressure scenario here. So yeah, let's dive in. In a previous visit, a physician instructs the patient to obtain a blood pressure device and monitor their blood pressure at home after seeing high readings in the office. The patient returns to the office with a validated blood pressure device, and a nurse provides training and education. So that's about 20 minutes. Over the course of a week, the patient takes 12 blood pressure readings following the established protocol and logs those readings into the patient portal. A medical assistant checks the readings in the portal and takes an average. The medical assistant relays to the physician, who then confirms a diagnosis of hypertension and develops a treatment plan. And lastly, the physician calls the patient and discusses the treatment plan and to continue the monitoring. And that's a 15-minute phone call. So Leslie, what's your guidance for this SMBP scenario?
Sure. Well, let's go to the next page. And again, we've got 2 encounters here. So encounter number 1 for education and calibration when the patient first comes in for management and education on the device, you would use code 99473. So that's your self-monitored blood pressure using a device calibrated for clinical accuracy. And again, this is designed to encompass the patient education, training, and device calibration portion of the care that's being delivered. The second one, when the readings are being gathered and the patient is taking a look from the treatment plan perspective and what the physician needs to do, this is where you have code 99474. So 473 is patient education, device calibration. 99474, you can see the description here. There's a number of parameters within it, but the idea for this one is making sure that that data has actually been collected. It's given to the physician and or QHP, and they are responsible for creation or modification of a treatment plan for this patient. So there are some activities that perhaps clinical staff can do in helping to gather the data. The physician's evaluation and impact on the treatment plan is what's most appropriate here. Let's go to the next slide and talk a little bit about some of the criteria for this one. So again, with 99473, this is the patient education device calibration code. Again, clinical staff may perform that under physician or QHP supervision, but that's taking to them. And again, if you have a physician who wishes to do that themselves, there's no reason that they can't, but the code will allow for some of that with the appropriate supervision to occur. 99474 is the evaluation and treatment plan setup modification for that patient. So a few key items. As we indicated before, this is a code that allows submission of readings in non-digital formats. So if you literally have a patient who is writing their blood pressures on the back of an envelope and bringing it in paper, they can actually do that, which also gives a little bit more flexibility for patients who may not have that digital and electronic setup. And it gives more access in terms of care. The physician or QHP does exercise decision-making and treatment plan formation or adjustment. That's going to be key on this code, that the physician or QHP is actually performing that part of the service. Clinical staff may assist with some patient communication or gathering some of the data, but making sure that that decision-making and treatment plan is happening with the physician or QHP is key. Now, this is one, we've set up this scenario such that this code is reported because right now this is all that's happening in scenario number 2. We're just taking a look at the blood pressure readings. We're modifying or setting up that treatment plan. Oftentimes, this service can occur in the context of a broader E&M visit. If that happens, if the services are provided on the same day of an E&M service to the same provider, those services are considered part of the E&M service and they're not reported separately. So that's one key item. It's really kind of folded into the rest of the E&M service. In that case, you would not necessarily see 99474 by itself. You would roll it into all of the other elements that you did for the broader E&M service that was represented. So that's a little bit of a difference when it comes to 99474. Sometimes that's done. It's not always reported separately. So take care if it's done in the context of a broader E&M visit. Okay, I think that's most for this one. Nard, we want to go to our summary?
Yeah, so let's close things out here. And we just wanted to share a few key takeaways, for the audience. First of all, there's so many new codes available now that can support, you all as you implement digital medicine services. We can only touch on a few of them today. So we definitely encourage everyone to take a look at the other scenarios that are outlined in the coding handbook. And also we recommend that you just partner with your coding and billing teams so you can take all of this coding guidance and really work together to build out those processes at your organization. Things that focus on documentation, the payer contracting and coverage status, and ultimately your claim submission and payment. So lots of moving parts here, but hopefully you can partner with other folks in your organization to really make things work to support digital medicine and care delivery. And Leslie, anything else you want to point out on the CPT side?
Sure. So from the CPT side, for the telemedicine codes, again, our telemedicine codes are new for 2025. reporting is evolving on these, and it's evolving at a pretty fast pace. My one key recommendation is make sure you check with your payers on how they wish for you to report. And I'll actually step out in front of this one. It's not too surprising. I think it's pretty well known at this point that while we have instituted these new telemedicine codes, at the time of this webinar, CMS has decided to take a slightly different path in terms of how they would like telemedicine visits reported for their constituencies. While we have new codes that do not require modifiers, they are currently recommending for Medicare reporting that you report the what I'll call the original office or other outpatient visit codes with an appropriate modifier, either 95 for audio-visual or 93 for audio only. That is going to be a variance from CPT reporting guidelines. And just to note that because they have chosen at the moment to not recognize the new telemedicine codes, what may also occur is that we may not see as much guidance coming from CMS in terms of how to report those new codes if they've opted not to adopt them. I highlight that because while not every payer has to follow what CMS does, certainly it's looked at. And so we would expect that there might be some higher levels of variation in how other commercial payers will decide to accept and use those codes in their reporting guidelines. So always check with your payers, especially on these new codes. For the RPM and RTM codes, things to remember is that those codes have been created for different service components. Again, education, supply, monitoring, treatment plans. And the key with really using them is just make sure that you match the codes you report with the services you provided at that particular time. So there are little composites to think about. For all of the codes, strongly suggest that you verify your reporting timeframes and requirements. A lot of these digital codes, especially if it's recording and processing data, they reflect activity over an extended period of time. 30 days is very common. And you want to consider how your systems also can capture the data you need to meet those requirements. And while we've given you highlights today, certainly taking a look within the CPT code set and some of our professional guides to make sure you've got the full instructions and guidelines for the best use of those codes. Those are probably the three kind of highlights I would give people for today in terms of telemedicine and RPM. So Nara and Amanda, I think if we have time for a few Q&A, perhaps we can take those.
Yes, definitely. Thank you, Leslie. Thank you, Nar. Wow, this is such an important topic. We have questions streaming in, and we were able to receive a number of questions ahead of time. So I'm going to go to a few of those. We had a question come in about digital visit codes and crisis codes being billed together. Can you speak to that a bit, Leslie?
Sure. Yes, so this was the question, and the question was whether or not digital visit codes, now we weren't sure what the visits were, but I'm going to make a presumption that you're talking about digital E&M or telemedicine codes, and crisis codes are psychotherapy for crisis codes. And can they be billed together? And the answer is actually yes, they can. And there's going to be a little bit of information that should be posted this Friday to help everyone with this. And I'm going to explain it a little bit. So according to CPT guidelines, they do state that when you have a psychotherapy for crisis code, the base code there is 90839, that you cannot report that with other psychotherapy codes, the 90832 through 38 series. However, there are no adjustments that say you can't report 90839 with an E&M visit code. Prior to 2025, our E&M visit codes, the ones most likely to be chosen from an outpatient setting, would be our 99202 to 205 series or 99212 to 215 series for established patients. Now, many people have written in because with the 2025 publication, there was a question as to whether or not these new telemedicine codes, these new telemedicine E&M codes, could be used the same way those original E&M codes could also be used, and that the guidelines didn't seem to quite reflect that. Well, I'm happy to report that that actually has been taken up by the CPT editorial panel at our most recent meeting. And hopefully this Friday, as with any code set, there are times when we publish errata or technical corrections to help clarify the intent of the editorial panel. And this one is no different. So by this Friday, and Amanda, if I don't have the link right now, I'll make sure we get it sent out to our attendees here, that there will be a technical correction that will be issued. And basically, it goes through with the guidelines for telemedicine services, and where appropriate, if we've referenced use of those original E&M codes, officer their out visit codes, that the telemedicine codes will also be added to those instructions. So what that would enable you to do is to say if you had a telemedicine visit with a patient and you needed to also report a psychotherapy for crisis code, and all of that was performed in an audiovisual manner, it would enable you to use the new telemedicine codes as well as psychotherapy for crisis codes together. And this edit also, we had can report psychotherapy add-on codes with the new telemedicine codes. This technical correction will address that as well. And I believe it will be retroactive to January 1 of this year. So watch this space, and I'll make sure, Amanda, that we have that list on the AMA website where people can actually go and download that. So in addition to your code book, you have the initial technical corrections with all of the edits in the guidelines. So if someone says, wait a minute, that's not in the book, you can say, well, it's technical correction. It's right here. The AMA said so. So watch for this space by the end of this week. That should be ready.
Wonderful. Thank you so much, Leslie. If we could go to the next slide, I think this will be helpful for the questions that have been pouring in. We do have an email specifically for these types of questions. If you're looking for specific questions about CPT coding scenarios, go to CPT knowledge base at ama-assn.org. That way the whole team can take a look at these questions. Obviously, Leslie and NAR's information is available there as well, but please direct your specific questions related to this webinar to that inbox. I think we might have time for just one more. Leslie, if we can, there was a question that came in about remote physiological monitoring and the amount of required interactive time involved in that code.
Okay. In terms of interactive time for remote physiological monitoring, there is, I believe this is probably in relation to code 99457. That's usually where we get the discussion. That is our remote physiological monitoring treatment service. And the code itself indicates that there's a total of 20 minutes of work time, if you will, that needs to be reported over a 30-day period for that code. One key thing to remember is that there does need to be an interactive component with the patient. It does not need to be the full 20 minutes. And actually, one of the things, Amanda, that I'll make sure people have is an excerpt from one of our articles that we write in CPT Assistant. That is our monthly newsletter. It's the official guide for guidance on proper coding for CPT. And we actually wrote an actual question and answer specifically about this. So I'll make sure that you have the more detailed numbers. But for a while, there was a misconception that it had to be a full 20 minutes interactive with the patient every month. That's not always, the optimal care plan for a patient. So we wanted to clarify, yes, it's 20 minutes of work, but it doesn't all have to be 20 minutes interactive with the patient.
For additional resources to support your physician or staff, please visit the American Medical Association website or stepsforward.org. Thank you so much for joining us, and we hope to see you again soon.